This is my topic. I was hoping that juniors would be there, but most of the senior and teachers of my teachers are sitting there. So, but this is an important, as Dr. Saab talked about the anti-lipids. So similarly, anti-platelets are the corner therapy of any ischemic event, whether having cabbage, whether having stenting or anything. So these are the objectives: to utilize current practice guidelines for the management of antiplatelet therapy in coronary artery disease patients, discuss the selection of different antiplatelet medications, determine optimal duration for how long should we continue single or dual antiplatelet therapy in patients of ACS or undergoing PCI or post-PCI, and we need to assess cardiovascular risk versus bleeding risk. So these are the drugs which are said to be the antiplatelets. You know about the aspirin, and we have had a session in the morning. We talked a lot about the aspirin used for decades, having a unique mode of action, but nowadays, for the last couple of years, there are certain reservations that it should be used only in high-risk patients and especially for the secondary prevention. So aspirin mechanism, you all know that how do they work? By cyclooxygenase pathway and then suppress the thrombin A2, and then other are the clopidogrel bisulfate. These are the and the ticlodipine and prasugrel, and the latest one is the ticagrel, and you all know that they inhibit the P2Y12 inhibitor at the surface of the platelets. And others are the diparadimol and the salastazole. They are the phosphodiesterase inhibitors. So everybody knows the mechanism, and this is the slide which tells us that all these drugs, and two are the active drugs where other are the prodrugs. So aspirin and the ticlodipine are the active drugs. So this is the mechanism of action. I don't want to go in detail because everybody knows that how does the aspirin work for the. So this is interesting that I have selected few studies on each drug, only 2 or 3. That this is the physician's health study in which 22,071 male patients. So this was done on the male patient, and remarkably it showed that there reduces risk of myocardial infarction among men. So there is no doubt about it that it reduces the myocardial infarction, fatal, non-fatal, or total MI. But this is in females, women. Aspirin does not reduce cardiovascular events among women. This is the primary prevention trial from the Women's Health study in which 39,876 women were randomized. So this is interesting. Males में बड़ा अच्छा फर्क दे रही है और females में. This is another primary prevention trial, antithrombotic trialists collaboration, which says that it reduces the risk of MI and vascular events, but at the expense of bleeding. So we need to balance, and we need to think the risk factors, whether patient is high risk for ischemic episode or he or she is high risk for bleeding episodes. So these are some trials which said that aspirin reduces the risk of ischemic events, but with the higher rate of bleeding. So we need to keep in mind while using the antiplatelets all those things, but there is no two thoughts, just that in secondary prevention, it reduces the risk of adverse cardiovascular events, whether acute MI, whether CVA, prior MI, prior CVA, other risk factors, and peripheral artery disease. In secondary prevention, there is strong recommendation, especially in the high-risk patients. So over the past several decades, there has been great interest to identify individuals for whom the clinical benefit of aspirin for the prevention of first attack or stroke, that is primary prevention, exceeds the risk of bleeding. So meta-analysis of early primary prevention trials of aspirin suggested a modest benefit of low-dose aspirin in the prevention of first attack or stroke at the cost of excessive major bleeding. Professor Mansoor Saab is not here. He was talking in the morning that those patients who are continuously taking low-dose aspirin, even their hemoglobin should be monitored after 1 year, and their stool DR must be checked for bleeding. So another remarkable drug, that is clopidogrel P2Y12 inhibitor. You can see the slide. I have selected only few studies that it shows that dual antiplatelet therapy is more efficacious in non-ST elevation acute coronary syndrome. And here you can see there is very much significance. In 12 months, p-value are very much significant. Another trial on clopidogrel, that is CREDO trial, that is clopidogrel for the reduction of events during observation trial. That also proves that dual antiplatelet therapy produces greater benefit when used for 1 year. So it provides slightly greater risk reduction than aspirin. Dual antiplatelet therapy along with aspirin and clopidogrel produces greater benefit when used for 1 year in non-ST elevation acute coronary syndrome. It produces greater benefit when used for 1 year in post-PCI patients. It produces greater benefit in medically managed ST elevation MI patients, and routine use of dual antiplatelet therapy for high-risk patients showed no benefit over aspirin alone. So this is an important that we should restrict ourselves to single antiplatelet therapy if we are using for routinely. And another drug, that is prasugrel. These are novel two drugs, prasugrel and the ticagrelor. So this is a Triton 38 trial which shows that prasugrel reduces ischemic events. Of course, the p-value is very much significant, but we can see over here that the bleeding events are also significant. The TEMI major bleeding, p-value is 0.03, life-threatening, non-fatal, and fatal, all are significant. So we must look at the risk of bleeding, that whether patient is high risk for bleeding or high risk for ischemic events. So another trial, that is Trilogy ACS trial, which also said that prasugrel does not provide benefit in medically managed non-ST elevation ACS. And one study says rather in non-ST elevation MI, it's contraindicated. So this is summary of prasugrel, that medically managed, no benefit of prasugrel or clopidogrel, except in patients undergoing angiography or in patients with no prior stroke or TIA. Invasive management, PCI with no risk of bleeding complications. Reasonable prefer prasugrel over clopidogrel. And in patients over 75 years of age and less than 60 kilogram weight or with prior transient ischemic attack, prasugrel is not recommended. So another ticagrelor. So again, this is a Plato trial, very much talk of this a few years back. Everyone was talking about the Plato ticagrelor. So it reduces ischemic events with no high rate of bleeding overall. So this does cause less bleeding chances than the prasugrel. So another Pegasus TIMI 54 trial, this is also shows, and here it was compared with the placebo. It shows a significant result, but the doses, whether 90 or 60, there were the same results. Another Pegasus TIMI trial, you can see over here that in all sorts, cardiovascular death, MI, stroke, cardiovascular death or MI or stroke, ticagrelor is much better than the placebo. So we need to balance the life. We need to consider the risks of whether the patient is at high risk of bleeding or at the high risk of ischemic events. So we need this sweet spot. So I always say that life is successful when there is balance in life, when there is discipline in life. So we need to count the bleeding risk by assessing the clinical variables, procedural variables, and scores. I don't want to go into the detail of each, but just we need to assess the bleeding risk by 3 factors. And then at the same time, we should also note the antiplatelet responsiveness. Even a few patients are there who are non-responders, are having resistance on aspirin. So we need to assess the function of platelet by platelet function testing. and genetic testing. And third thing, at the same time, we must monitor the ischemic risk, that is clinical variables, procedural variables, and at the same time, there are scores by which we can easily assess now on the our mobile phones. We can assess that this patient is at high risk or this patient is at low risk, or what are the scores. So this is 2023 American Journal of Cardiology says that this is the summary, that individual bleeding and thrombotic characters must be kept in mind, that if the patient is prone to bleed, then you must restrict yourself even on the single therapy. And how long should we use this drug even in post-PCI patients? You can see over here that standard duration, that is 2021 American College of Cardiology says that it's class 1 recommendation for 12 months. But European Society of Cardiology says it's class 1 recommendation again for 12 months. So aspirin along with ticagrelor or prasugrel are 75, but we need to assess the risks. So and shorter duration if we want to use, especially in those patients who are high risk for bleeding or overt bleeding on DAPT. Again, 2021 American College of Cardiology says it's a 2B, whereas ESC says 3 months, that is a 2A. So, and those patients who are having balancing ischemic and bleeding risk, we also need to discontinue, we may discontinue the aspirin, and we may use ticagrelor or prasugrel or clopidogrel. So decision is on the basis of individual patients, that what are their risks. So after stent implantation, let us simplify that aspirin dose in PCI patients is 81 is enough. Regardless of stent type, ideal duration is 1 year. Dual antiplatelet therapy in PCI or stable ischemic heart disease, dual antiplatelet therapy in PCI for ACS patients, bleeding risk, previous bleeding on DAPD and oral indication are the coagulopathy, all should be considered. So stable ischemic patients consists of aspirin and clopidogrel, bare metal stent if we have implanted, then 1 month is minimum, and current drug-eluted stenting 6 months minimum. If no bleeding risk continue longer in both groups, may be reasonable to stop P212 inhibitor after 3 months. If the patient develops significant overt bleeding or at risk for severe bleeding complication, that is major intracranial surgery. So in acute coronary syndrome patients, 12 months for both bare metal as well as drug-eluting stents, reasonable to prefer ticagrelor over clopidogrel, reasonable to prefer prasugrel over clopidogrel if the patient is not at high risk for bleeding and do not have CVA. If no bleeding complications or bleeding risk is low, we may continue longer than 12 months, and drug-eluting stents patients may discontinue P12 Y12 inhibitor after 6 months if there is a high bleeding risk. So, on conclusion, dual antiplatelet therapy is indicated at least for 1 year after ACS. Duration of antiplatelet therapy is based on ischemic versus bleeding risk. New generation stents, dual antiplatelet therapy, shorter in special situations, and patients with pre-MI benefit with extending dual antiplatelet therapy beyond 1 year. So calculate bleeding risk for ischemic risk in assessing duration.